Who wants to be in France when you can be in Columbus, right? Well, thank you so much. It's always a pleasure to be here with Ken, and the work that they've done at the Higher Education Center with Dr. Clapp is just really awesome. I was commenting on the website. There's just a lot of momentum now in college health that hasn't been there in the past decade. And I think that college students are now seen as a population of in need of better services, and I think that that's where the research can be informative. So I'm going to focus on the non-medical use of prescription stimulants today, and give you first some national ideas of prevalence, how big the problem is. As a good epidemiologist, we always have to set that sort of stage, and then tell you a little bit about the College Life Study, what we know about this problem from not only the College Life Study, but other studies of college students around the country, what we suspect, what we're not totally sure of, but what we think we're sure of, and what we can do, which is the most important. So national estimates of prevalence are important. There's a lot of sources of data out there for you all that track this problem at the national level. There's Monitoring the Future, there's the National Household Survey, there's some CDC data, but it has limitations, and so it's always necessary to complement what you can find in the national data with more research-based estimates from more particular studies from single universities. So we're going to show you both. So this is a line that is illustrates progress. If I could get the laser pointer to work, I guess not. That green line shows the prevalence of non-medical use of any prescription drug in the past year among adolescents, so 12 to 17-year-olds in the national data. And that really is driven by the decrease in prescription opiates in the past year, which is a good thing. So we are making progress, so that's good news. What's staying fairly flat are the other types of prescription drugs, including stimulants, sedatives, and tranquilizers. And again, the past year non-medical prevalence among 12 to 17-year-olds is 1.8%. And that is the national estimate. And like I said, these have limitations because of the way the questions are asked, and so it's better to look at some of the other data points. When you get to 18 to 25-year-olds, the graphs look a little different in terms of the magnitude of the problem. It's a lot higher. And you can see the overall progress until 2011. There was a little bit of a bump in 2012. And what you see is that past year non-medical use of any prescription drug is 13.7%. And that is driven, again, by pain relievers most commonly, and stimulant use and tranquilizers following that. And sedatives are at the bottom. What's interesting is that prescription stimulant use is the only class of prescription drugs that are used more commonly among college students than non-college students. So when you look at the population level, it's more common to find prescription drug abuse among people who are not going to college, who are not college educated. But for stimulants, it's more common to find stimulant use in college settings, which we'll talk about. When people talk about 1.5%, sometimes they don't realize that that translates into 658,000 students. So that's a big number, and for policymakers, that speaks more loudly than 1.5%. When you look at gender differences, people always ask about gender differences, but overall, the bottom line is that we're not really finding tremendous gender differences in prescription drug use. With other drugs, there's sort of a male predominance of other types of drugs, but for prescription drugs, it appears to be fairly equal for genders. The College Life Study began in 2003 as an effort to really take a look at a wide range of health risk behaviors And one of the major focuses of it was drug use during college. And NIH had not funded a study of college drug use before the College Life Study came around. And so we began by screening an entire freshman class at a single university in the Mid-Atlantic. And what we did was we selected a sample for longitudinal follow-up consisting of 1,253 students, which every year we re-interviewed. So we conducted face-to-face personal interviews with them every single year and got great response rates because of incentives and my great staff in terms of their tracking methods. And we follow them regardless of continued college attendance. So we're in our 10th year now, and 76% of the sample is still active in the study. But during the college years, the response rates for follow-up were in the low to high 80s. We measured a wide variety of things. The outcome measure in a lot of our research has been illicit and non-medical drug use, but the predictors of those things came from a wide variety of domains, including high school behaviors. We didn't collect measures on their parents, but we looked at their reporting of their parents, monitoring during high school, mental health, stress, and a whole lot of other things we added in as non-medical drug use sort of became of age in the early 2000s. So we were able to add very specific questions about non-medical use and diversion and motives and all kinds of things. So what do we know about this problem? The first thing is that different drug classes equal different harms. So when reporters call and they want to talk about prescription drug abuse, I always make sure that we're on the same page in terms of what prescription drug are we talking about, because there's a wide range of different effects of different types of prescription drugs. We always want to make sure that we understand what we're talking about. Non-medical use has become very widely understood now to be use of your own substance, your own prescription, more than was prescribed by a doctor in ways that wasn't prescribed, or using someone else's prescription, which is a more common way of defining non-medical use. We're going to talk about motives, and then I'll show you some other research studies of college students, and we'll talk about sources, access, and availability, which we all have a lot of data on. So the reason why I feel like we sort of can check the box on these topics is because there's so much research all saying the same thing on these things. Now what we need to do is sort of move into a different area on what to do about it and the effectiveness of interventions, because this is sort of coming up over and over again as things that we know. We also know that diversion of prescription drugs is highly prevalent. That's an area that we really, really need more intervention on, because people who have prescriptions are diverting it at a high rate. We know that some of the things driving this problem is this sort of overinflated perception of how many people are actually involved with prescription drugs. We know that expectancies play a role. We know that some groups on college campuses are at higher risk than others. And we also know that there's a strong association with other drug use, that this is complicating the landscape of drug problems among college students. It's not a separate problem. It's just making our job more difficult. I found this in I like to collect old magazines, and this was a March 1948 Mechanics Illustrated ad, well, not an ad, an article about a child that took these white pills to increase his IQ. And the title of it is Pills That Increase Your Intelligence. So even back then, people have always been searching for some kind of pill to shortcut the work that you need to do in order to be smarter. What are the motives? Over and over again, the research has shown that these are very consistent motives for prescription stimulant misuse: curiosity, improving concentration, staying awake longer to study, or to party or drink more, which we tend to forget sometimes, get high, or there's some work by Christian Teeter showing that for girls, stimulant use and opioid use is used to relieve depression symptoms, but that's a motive. And we have to remember that motives are not the same as risk factors. So risk factors are things that we as researchers can identify as targets for intervention. Once you control for all other things, it really is driving the problem. A motive is why someone thinks that they're using it. So it's very important as preventionists to make sure that we're targeting risk factors and not just simply agreeing with the person and saying, oh, well, we need to change that motive because you're using it to increase your academic performance, but we can't take them at their word that it really is, because when you look in the research, it tells a different story. So this is a picture of Cornell that I really like, so I thought I would use it for this break in the talk about research studies of college students. Brings me back home. Although it only looks like that very few months of the year. Most of the time it's coming from Southern California to Cornell, quite a shock. Okay. This was another study done by Christian Teeter and Sean McCabe out at the University of Michigan. And this was a nice study because it looked at the trends over time in a single university of the different classes of drugs. And what you see is that blue line is actually any medication, any prescription medication, and that's showing an estimated prevalence of about 14% in 2013. And what you're seeing is a little bit of an uptick in stimulant use from 2009 to 2013, which is kind of interesting, and a decrease in prescription opioids. So it appears from the national data and from this that we are making probably more progress in the prescription opioid problem than we are in the prescription stimulant problem. This is data from the College Life Study looking at it in a different way, where every line represents a year. And so this shows the first 4 years of college. And what you see is the drugs listed at the bottom: marijuana, prescription analgesics, stimulants, and so forth. And by the time a student in the College Life Study left college in year 4, 63% of them had used marijuana at least once during their college career, and 30% had used a prescription stimulant. What's important about this is that there's a big gap between the first year and the second year, which is the period of greatest incidence of prescription stimulant use. So that's a point of intervention, really that first year, and we're going to talk about why that might be true. For prescription analgesics, 23%, prescription tranquilizers, 13%, cocaine also 13%, which is quite notable. But when you look at how often prescription stimulants are used among people who take them, it's not very often at all. So this is years 2, 3, and 4. Among users, how many times a year did a user take the prescription stimulant? And if you were prescribed a prescription stimulant for ADHD, this number would be 365 if you were taking it every day. But what we find is that really people are using it very sporadically and infrequently. Now, is this not a problem because they're not using it frequently? I would say no, because what we have found is that it's a signal for a lot of other problems. And every time they take it, there's a risk associated with taking it. But it's good to put this in perspective, that when we talk about prescription stimulant use, we're not talking about something that's highly regular. It's very infrequent for the majority of people. And then students with ADHD, how often do they overuse their own medication? That's a problem too that is sometimes overlooked. So we find non-medical use among people with ADHD. They're prescribed it, but then they overuse it. And I don't know why, we haven't figured this out yet, but 16% also use someone else's prescription stimulant non-medically. That was in our study. And then in another study from Harvard, 22% misused or took too much of their medications, which is similar to our estimate. So there is non-medical use among people who have ADHD. So that's another target population for interventions. We can't forget about people who have ADHD. We know this is so consistent that friends and peers are the most consistent sources of prescription drugs, both stimulants and opioids. And this shows over 4 years of data, same thing over and over again. It's a friend with a prescription who's diverting the meds, and that's where they're getting it. Very few are going to the internet, very few are doctor shopping. They don't have to. It's widely available from friends. And in terms of the cost, the interesting thing that we found is most people don't pay anything for it, but in the later years, they seem to be buying it more, and that could just be because the more regular users are willing to pay for it. Diversion is a problem, and there's not enough research on diversion necessarily, but in our sample, 60% of students with ADHD shared or sold their prescription stimulants, and 35% of students with a prescribed analgesic shared or sold their medications. So this is definitely a way to intervene. This is really a huge target for us. I told you before that overestimation is one of the things driving the problem. And when this is sort of a graphic to describe the results of a study where at the same university people were asked, how many of your peers on this campus are using prescription stimulants non-medically? And the answer is always around 75%. But on that same campus, when they surveyed how many people are actually using prescription stimulants non-medically, they came up with about 10%. So there's a huge difference between what they think and what people are doing. And people who overestimate are more likely to engage in the behavior because they want to be normal. They want to be average. So one of the sneak previews for what we can do about this is we can correct those misperceptions. And that might go a long way to sort of making the behavior seem more deviant, which people don't want to do. Non-medical use is also associated with sort of distorted perceptions of things. And one of the distortions is that they have high levels of positive expectancies about the benefit that it will bring to them, that it'll work, it'll make me smarter. And in the same way, they have low levels of negative perceptions about the consequences. They don't think that they're going to get in trouble, and honestly, from what we see, is there's not a whole lot of sanctions going on for people getting in trouble. So that perception is actually accurate. High-risk groups are people who attend competitive colleges, more selective colleges, the Greek community. Although everyone is at risk, you always have to remember that everyone is at risk, but these are sort of high-risk groups, higher than average risk. Students who are academically struggling, this whole idea of people who aren't not risk-aversive, who are sensation-seeking, and students who perceive these drugs as benign and safe to use. So the research supports all of these things as risky groups. But one of the most important things that I try to drive home is that non-medical prescription drug use is really associated with alcohol and other drug use when you look at the literature. Past year prevalence estimates for marijuana is beyond 85%. Cocaine use, comorbid cocaine use is 35 to 60% of people that are using a prescription drug non-medically are also using cocaine. That is so much higher than the average college student. Ecstasy, 52%. And then the overlap with prescription stimulants and analgesics. So 44% of those who used a prescription stimulant are also using an analgesic. So what this does is it complicates the problem that we have because we're dealing with a polydrug use problem. We know that for stimulants, non-medical use increases the risk for illicit drug use. The non-medical use comes before some of those other drugs, except marijuana and alcohol. Medical overuse also increases the risk for illicit drug use. But medically supervised use in an ADHD positive student does not appear to increase the risk of illicit drug use. And this is a very important point to hammer home in the high school age, where parents are afraid that if they treat their child with ADHD, they're likely to go on and use other drugs. The research strongly supports that that is not the case and that it's actually protective. So that's an important thing to remember. This is just some data showing the overlap between prescription stimulant and other drug use. And as you can see, it's a lot higher in the non-medical users of prescription stimulants for almost all types of drugs. We know that marijuana and other drug use is associated with academic performance problems. And what we have found over the years is, to make a long story short, the marijuana and other drug use is leading to academic performance problems, which sort of makes non-medical prescription stimulant use very attractive to a person who's academically struggling. So they use it as a compensatory behavior during times when they feel like they need an extra shortcut or sort of a boost. But this does not prove to be successful. This is a largely unsuccessful method of increasing your grades. And we've shown, and other people have shown in a cross-sectional way, when you take a snapshot, non-medical users spend less time studying, they skip classes more often, and they earn lower grades. And this is a sort of a schematic of how this seems to work, and it simplifies a very complicated structural equation model that I would never present to a conference, especially after lunch. So here you show what your grandmother would have told you, that if you skip class in college, your academic performance is going to decline. But what's behind that? It seems like marijuana and other drug use leading to more marijuana, which they can use every day, by the way, leads to skipping class, and then the skipping class is related to prescription stimulants for studying. One of the new things that we've been looking at more recently is this idea that these other things are important too. So what's behind this need to use prescription stimulants as a shortcut? Not everyone does it, right? So what may be behind that? And these are some interpersonal factors that I'd like to share with you. The first is academic self-efficacy. One of the things that I'm trying to sort of characterize is what are the things that we can put out there in the literature and in practice to promote, rather than have things out there to say, you shouldn't do drugs, you shouldn't do this, you shouldn't do that. Can we turn it on its head and say, what we want to do as preventionists in the substance use area is we want to promote academic self-efficacy, which is having confidence about your ability to complete academic tasks. So we want to promote that. And what we have found is that students who are less confident about their ability to avoid non-medical prescription stimulant use when they had a lot of work to do in a short period of time were more likely to use. So those who felt like they really needed it. The other thing is that the more students procrastinate, the more likely they are to take shortcuts. So it seems like academic self-efficacy is something that we should be paying a little bit more attention to. One of the suggestions by a researcher in 2015 was that a possible solution to improve self-efficacy is to create a personalized study plan that outlines study goals in more detail, study times, what's your learning goals, and really breaks it down for people in maybe an academic assistance center to sort of promote this idea that you can do it. You don't need these other things. And this is just a schematic that I'm working on. This is sort of a work in progress. But if you look at what predicts academic self-efficacy, it could be your experiences with failure or your experiences with success. If you've been very successful, you're probably going to feel like you can be more confident and go to class and really buy in to the academic pursuit that you're looking for. Practice, it simply is a matter of doing it over and over and over again when people get good at it, right? That's what, if you look at any of the stories of Tiger Woods or Greg Louganis or anyone who has achieved athletically, what they do is they practice over and over again. It's just muscle memory. So it's this fear of not doing well that may be holding students back, and they just don't want to practice because they think they might fail. And I think that that's something that puts them in a position where they procrastinate and then pull away and then find themselves in a position where they're struggling. The other thing that could influence academic self-efficacy is all of the things that they've been told by other people, starting with their parents all the way through their peers about how good they are at what they do, right? So that can also influence academic self-efficacy. But I think if we were to promote academic self-efficacy and find ways of improving it, we could go a long way to improving academic performance without the need for shortcuts. The other thing is this whole idea of risk and reward. We know that people who feel like things are risky are less likely to engage in a behavior. But with prescription stimulants and to a certain degree prescription opioids, they might have this added benefit, right? It might make me feel less emotionally in pain, or it might make me concentrate more. There's this added benefit, perceived added benefit to it. And does this added benefit outweigh the reward? So you have different types of people who are thinking about it as risky or thinking about it as rewarding. And we know from the data that people who perceive lower levels of harm are more likely to use prescription stimulants and analgesics. So one of our prevention messages is always to talk about the risks involved of using drugs, because if you perceive the risk to be high, you're less likely to use. I got a call from Glamour magazine like a couple weeks ago before I left, and the woman from Glamour magazine said, well, could you tell me about the risks? Because this woman said, I think that our users, the ones that we surveyed in our study, just think that using drugs once or twice or even regularly, right, it's not really associated with any real risks. So tell me what the risks are. And I rattled off the health risks and the possible complications, and you shouldn't be using drugs that aren't prescribed to you because it's not a doctor prescribing it to you. She's like, oh, that's just not doing it for me, okay? And I'm like, geez, and I was walking and I was outside and I'm like, oh no, I'm gonna say something and it's not gonna make sense to people who read Glamour magazine. And I put myself in the position of a person reading Glamour magazine, which I don't do anymore. I was probably 13 the last time that I read Glamour magazine. And I told her that, well, maybe it's the reliance on a drug instead of building yourself up, like your own self-esteem to go to a party, to talk to somebody, and maybe it's that heavy reliance on a drug and not practicing all those things that you need to practice to become a better friend or a better worker, and I'm just thinking about this off the top of my head, and she's like, that's wonderful. I love that. I'm like, go ahead. No research to support it, but go ahead and put it in your article. But it gets back to this idea of self-efficacy and this idea that you are good enough. You're good enough to succeed. You're good enough as a friend. Or do you need these other things to walk into a party or to make a friend? Okay, so let's talk a little bit about risk and reward. Perception of risk and perception of reward might not be just the flip side, two sides of the same coin. Perception of risk of drug use is probably driven by your own individual risk-taking behavior, your sensation-seeking level. You're always the kid who wants to jump off the highest level of the diving board. I don't know why I'm thinking of diving analogies. Or the kid who wants to, take a lot of risks. It's also driven by your knowledge of risks, right? If you're more informed, you're more likely to understand the risks involved. And that's something that your parents can tell you, or that schools can tell you, or that you can read about, or that your friends can tell you. So that's how your perceptions of risk are formed. But with perceptions of reward, it's really interesting because you've got two competing rewards in college. You have a drug benefit reward, but you also have a reward associated with academic pursuits. So you've got two kinds of rewards that compete with one another, and that perception of which one is better is driven by your ability to delay an immediate acute reward for something long-term. So if you were someone whose parents always told you to keep your eye in the future, that this is going to interfere, if you keep your nose clean because what you do here is going to interfere with your future later, you're going to sort of start to practice the idea of delaying that gratification, which is a good thing, and that's protective against drug use. But if you're one of those people who is always seeking immediate, acute rewards, you're probably more likely to say, well, screw the academic awards long term. I'm going to take something that makes me feel good and makes me feel good now. And this is something that clinicians might want to consider in their conversations with students. The other thing that influences reward perception is what their friends will think. Because today we tell a lot of stories to one another about how rewarding a memory is or how rewarding an experience was that might involve something very, very dangerous or risky. And so that itself has inherent value to a young adult. So that reward perception is the reward associated with being able to tell that story. So I'm just throwing this out there for those of you who are involved in this at a more clinical level. You sort of have 4 different types of people, to oversimplify it. And it can be, these 4 different types of people can be defined by where they are placed on an axis of low perceived benefit to high perceived benefit, or low perceived risk to high perceived risk. So in that light blue box, you have people who are not the troublemakers, who are sort of risk aversive, they're knowledgeable about risk, they're at low risk for other drug use, they're doing well, they have their eye on a future reward, not immediate rewards. And then moving along the axis of perceived benefit, you have people who are naturally risk aversive, but they are academically struggling, but they're still thinking about these immediate rewards versus future rewards. And then you've got the left-hand side where you have a moderate risk taker, misinformed, moderate risk for other drug use, doing well academically, high value placed on future versus immediate rewards. And then you have the red box, which are all of the risk factors all rolled up into one. So these people might be at the greatest risk for non-medical prescription stimulant use for sure, and other drug use in college. The other thing that might play into all of this, and maybe we could talk about this during the panel discussion. Ken wanted me to think about things that were more provocative for this panel, is when we talk about non-medical prescription drug use, it is not characterized as something like heroin use or a person on the street. The prototype for a drug user, when you Google drug user, these are the images that you get, okay? When you're a college student and you're thinking about non-medical drug use, these are not the images that come to your mind. So there's a mismatch in the prototype. This can't be drug use because that's what drug use looks like, right? So how can we be responsible and not stigmatize and make people look very, very unattractive who are drug users who need help, but also call it what it is. It is drug use. It is harmful. It's not something that is something where people should just be telling funny stories about. It's pretty serious, but not go to these extremes. So how can we change that prototype to make sure that we're giving the right prototype about the dangers of drug use? So what can we do in the last, I think I've got 15 minutes left, I think. Okay. So clinicians definitely monitoring medication and drug use. You probably heard this before, frequent office visits. Tim Willens at Harvard always says that for ADHD clients who come to him, he always, on the first visit, never prescribes an ADHD medication, always makes them come back for the second visit. And that sort of rules out people who are just drug seeking. It's a simple thing. Also, urine drug tests for ADHD patients, very, very important. In all of psychiatry, actually, it's good practice to screen for other drugs because we have a lot of students in our college life study who have multiple therapists for different mental health conditions, but they're not telling any of those therapists or clinicians or psychiatrists that they're smoking pot, using other drugs, and they're not being urine drug screened. So you don't know whether or not those mental health problems are actually a result of their drug use. And they may be prescribed psychiatric medications on top of using, and those therapists won't know. So urine tox screens are very useful in that case. Prescribing medications with lower abuse potential, it's the immediate release prescription stimulants that appear to be related to non-medical use, not the longer acting types. Dosing judiciously, discussing compliance. What about these extra doses that they may have? Treatment failures. Advocating for safe storage, having a therapist as well as a prescriber who can ask about the effects of the medication, like euphoria, cravings for other types of drugs, discussing the ethical and legal issues around diversion, making sure that people are responsible in terms of not diverting their medication. And it seems like the data on prescription drug monitoring programs are somewhat favorable, but I think that we need a little bit more research on that. So here's, for college campuses, here's kind of a summary of what college campuses can do to improve clinical practice, increasing vigilance regarding diversion, and not taking a stance that, well, we just can't have these drugs on our campus. Because that doesn't benefit students with ADHD. So you have to have the drugs available and accessible to students with ADHD and not make it, very, very hard for them to get their medication, but you just have to be smart about the way that clinicians are prescribing them. And making sure that ADHD patients are screened for illicit drug use. It's not a casual type of visit. Working with the counseling center, so there's this division at colleges between the counseling center and the health center and sort of working together on that. And also we advocate definitely working with academic assistance centers as a touch point for interventions, making sure that academic assistance center personnel know that when people are coming in and they're academically struggling, they may be at risk for marijuana and other drug use. Students have a role to play in this where they can spread the word to others about the true risks of non-medical use, sort of changing this drug use prototype, linking non-medical drug use to illicit drug use, and definitely dispelling this idea that these prescription stimulants are smart drugs. Students on medication, definitely getting across the message of not sharing, protecting medication from theft, making sure that if they are approached by someone who would like their prescription drug, that they encourage responsible help seeking and not just the easy way where I can give you a prescription that I have. Rather, why don't you go see someone and go through a clinical assessment? That should be the answer, not here, take some of my prescription. Parents, there's a whole list of things that parents can do. We found in our study that a lot of students would tell their parents that they're taking a friend's Ritalin, and the parents would condone it because it really didn't fit the drug use prototype. It wasn't drug use. They weren't telling them about the pot that they were smoking, or the amount of times that they were skipping class, or their lack of confidence about doing well and how they were academically struggling. Parents need to ask those questions in order to elicit those responses. Also, parents need to be educated that between 18 and 28 is the period of risk for emerging mental health problems. That's the highest risk period, and although parents want to breathe a sigh of relief when they send their kids off to college, that is the time when these things will occur. It's the last thing a parent wants to see or hear or experience is the signs of a mental health issue, but that is something that they need to be more aware of. Parents need to be more vigilant about their own medication adherence, role modeling of their proper prescription drug use, and then there's a whole list of things that parents can do early on and throughout the college years to reduce risk of drug use. Colleges and universities sponsor ongoing dialogues. This slide is getting old, Ken. It always says Ohio State on it. You guys are doing a great job in terms of pulling colleges together to raise awareness about this issue and to share experiences about what you're doing on campuses. I'm all for evidence-based practices, but I think a lot of times we need to be a lot more creative and identify models that are working on a college campus and bring that to light and say, let's study it, let's evaluate it. So it's sort of the a practice-based evidence approach. I think that I'm a big fan of writing stuff down, and a lot of colleges are hesitant to do this, but think about it as a strategic plan. Think about where you want to be in 5 years on your college campus. What do you want to have the prevalence of prescription drug use to be? How many people do you want trained? What kind of intervention programs do you want to have on your campus? And that's something that the Higher Education Center is really involved with. Simply, this is a simple one, have students rethink taking 18 credits per semester in the first year of college. This is a showstopper. When you get to college and you come and you think, okay, I got straight A's and I'm going to some selective college, and you take 18 or 21 credits because you think, and then you just totally fall apart, that is not going to promote academic self-efficacy and mastery. I think what people should really consider is taking small steps, achieving mastery, 12 credits in the first year, and then saving the 18 credit semesters for the later years when you can handle it. And enforce sanctions against diversion. That doesn't appear, sanctions and the legal aspects of all this isn't talked about enough. But it's definitely a tool that we can use, not as a gotcha approach and lock them up and throw away the key, but as a point of assessment where a student might be able to have that opportunity, have that experience to help them get back on track. And the other thing is that I'm sure you heard, Ivana left the room, but I'm sure you heard Ivana's passionate, her talk this morning, and I just think that we cannot give students in recovery a loud enough voice. I really think we need to start talking about the success stories of students in recovery, and just non-using students, not even just students in recovery, but just non-using students. They typically don't post posts on Facebook about what a great time they had studying and getting the A in the class. That's just not an exciting story. It's more important to post a story about how you think you might have succeeded on a test because you took some drug, right? That's how these things get perpetuated, and that's why the estimates are overinflated is because those are the stories that get perpetuated, not the ones that aren't using. This is some good news. This is hot off the press data from Monitoring the Future, and this is showing that the rates of abstinence from illicit drugs, alcohol, and cigarettes in high school are going up dramatically. Like if that was a stock, I don't do stocks, but if that was a stock, someone would want to invest in it because of the shape of that line. So in 2013, 62% of 8th graders abstained from all types of illicit drugs, alcohol, and cigarettes, versus in 1991 when that estimate was at 24%. This is awesome news for prevention specialists. This is making abstinence from all drugs more like the norm, and hopefully those 8th graders will enter into our colleges as non-users, and we know that the best predictor of use during college is what they did in high school. So I would expect that over the years we're going to find that avoiding drug use is going to become more normative. This is sort of our model for student success. Like I said, we're always trying to promote things rather than say things that we can't do. So we want to promote being cognitively strong, focused, motivated, and also knowing how to access support. And you can see our website for our publications and other resources, but I'm going to stick around for the panel discussion, and that should be exciting. I think we're going to take a break. Thank you so much.